Good evening, everybody. My name is Ghassan Abu Alfa, and I'm honored to be here tonight to welcome you all, and also honored to work very closely with my two colleagues, Dr. Richard Fenn and Dr. Anthony Query.
The following audio is part of a certified educational activity titled New Options, Emerging Combinations in Advanced Hepatocellular Carcinoma. Our management approach is poised for transformation. Access the entire activity and complete the post-test at www.peerview.com/PVM. Downloadable slides and practice aids are also available.
Current management of the advanced HCC, identifying opportunities to address unmet need. And I'll be doing this part, which is rather pretty short, but it will help us lay out the stage in regard to what's going to happen or to follow afterwards. This is a great layout that we use rather commonly to define the disease in regard to its stage or the extent of it being either local or metastatic. And same time, it has embedded within it a cheat sheet to tell us or direct us to what will be an appropriate therapy. This is what's called the Barcelona Clinic Liver Cancer Staging and Treatment Strategy, or the BCLC, as we all of us know. And simply, it shows that if we have on the extreme left a small lesion in a good liver, we take it out, either by surgery or by radiofrequency ablation. If we have a lesion which is rather still small, but the liver condition is not that great, this is a patient who might be eligible for a transplant. Of note that the transplant criteria were updated last year by the UNOS, were actually even larger than the criteria. If there was any reduction in size, they still can be eligible for certain points on the UNOS criteria for transplantation. After that, if we have a disease that's limited to the liver, not metastatic, and as such, not amenable to be resected or to be transplanted, then a local therapy in the form of either an embolization, i.e. trying to clot the blood vasculature and flow of the blood to the tumor, in addition to probably infusing some chemotherapy within, or in regard to yttrium-90, which is to throw the small embolic beads of radiation into the liver, will be an appropriate therapy as well. And of course, this brings us more to the right this time, and you can see that patients with more advanced disease, i.e. disease that's not amenable to those local therapies, or at the same time it has metastatic disease, this is where the systemic therapy will be applicable. And this is where we're going to spend almost most of the time tonight to really look at the applicability and the usage of the different systemic therapies. As you can see over here, the BCLC was updated by the Barcelona group to put in Sorafenib as the appropriate choice of therapy, because understandably Sorafenib was the only standard of care therapy from 2007 when it was approved until today. Regorafenib was added in 2017 last year, and that's why you see it as well. But the story is much more elaborated than this. We're going to hear about many more therapies, and some of them already have been approved, like the checkpoint inhibitor nivolumab, and some of them have positive outcome, and we're going to discuss them with you tonight. And understandably, for a patient with advanced condition altogether and patients not amenable to therapy, then best supportive care. Now, before I carry on, there is an important aspect in regard to the BCLC, and to give credit for the effort that was done on the BCLC by Dr. Bruges, is that at that time, the need for the map was really more understood in a vertical fashion, i.e. I have small disease, good liver, I take it out. I have metastatic disease, I cannot really remove it, and patients still amenable for systemic therapy, I'll give systemic therapy. But we never really discussed how things might transition in the horizontal fashion. In other words, we really never discussed how a B becomes a C, or how the transfer of the care will move from the B to C, etc. And interestingly, there has been collusion both ways, where maybe the C, i.e. systemic therapy, will push more into the B, or the other around, more of the B local therapy will push more into the C. And this is a part of the discussion that I will carry on at the completion of the part of the systemic therapy that my two colleagues will present, and we'll discuss it at that time. With this said, I come on to the general principles of therapy nowadays to just kind of set the stage. As you can see from the map that I just showed beforehand, this is a multidisciplinary team approach. This is not really one specialty that can handle specifically liver cancer. It has to be addressed by the different expertise, being a surgeon, interventional radiologist, hepatologist, medical oncologist, and the likes. Number two is it's very important to assess the curative possibility for the disease, being a resection or a transplant or RFA, as we discussed. On the other hand, understand the indication for institutional expertise in regard to regional therapy. Remember here, the word institutional is carefully chosen because no doubt that certain expertise have evolved in regard to embolization, bland embolization, chemoembolization, or even radio frequency ablation or radioembolization, as you know, to the term 90. In addition to that, no question that Sorafenib and Regorafenib, as we just showed in the BCLC, were the two drugs that first came, one to the market almost 10 years ago and the other one barely a few months ago. The use, indication, dosage, and side effects will be important aspects of how we develop the therapy. And this will apply for other therapies, including, of course, the other one which is approved, which we're going to discuss, which is Nivolumab. Evaluate the underlying hepatic function. This is very critical. Add to the understanding of the hepatitis status. We always say liver cancer is two problems in one: the cancer itself and the associated liver functionality issue, or the cirrhosis. And it's very important to address those two aspects and not to ignore one or the other. Add to this, the story on the hepatitis status will be very important, especially in regard to some applicability or responses to certain therapies, but more important in regard to the safety components that Dr. Al-Kuwer will talk about when we discuss the checkpoint inhibitors. It's very important to remember this great effort and where we are here today in regard to 5 therapies that already are with positive outcome, and some of them already are FDA approved and the others are on their way to be approved by the FDA. This is all because thanks to our great patients that we are trying to help per se. If they weren't for the patients that really joined on all those clinical trials, we will not be sitting here talking about all those therapies. And the same thing over here. Of course, none of us are acknowledging that this is the end of it or this is the end of the story. There will be more that is to follow, and by all means, we will continue to encourage all clinical trials for the patients to make sure that we improve further in regard to the outcome of patients with that disease. And this brings me to the last point, which is in the early disease, as you can see, with the treatment that are resectable in nature, we have to really understand that there is a high potential for survival, but it's not 100%. Unfortunately, many of the patients, despite the curative intent of the therapy that they might get, they will end up with a recurrence and they will require systemic therapy. In regard to even locally advanced disease, the chance for survival is not really a cure, and this is sometimes what's misunderstood. Embolization does not cure people. It will control the cancer, and as you can see, with a 2-year survival up to 40 to 60%, but doesn't mean everybody will be able to live to that extent. And in regard, of course, to the advanced disease, with the choices I'm bringing up here, at least we mentioned those that are FDA approved, the Sorafenib, Regorafenib, Nivolumab, and of course, add to the 2 more drugs that we're going to talk about, Lenvatinib and Cabozantinib, plus, of course, other clinical trials. No doubt that we are seeing more and more improvement in regard to the 1-year survival, and we're going even beyond the 1 year per se. So it's all good news, as we said, for the patient and, of course, for the disease itself.
Good evening. I'd like to thank the organizers for the invitation. It's an honor to share the podium with Dr. Abu Alfa, Dr. Al-Kuwer, giants in the field. And I will be talking about the current landscape, evolving landscape, as it pertains to non-immuno-oncology agents, which Dr. Al-Kuwer will follow. So we'll start with a case. Fairly typical, a 65-year-old gentleman, hepatitis C, some chronic medical problems, is in screening for his liver cancer, and is found to have a liver mass. These are his labs. You can see his platelet count is 94,000, so some evidence of portal hypertension, but well-compensated bilirubin, liver function, INR. Alpha-fetoprotein is markedly elevated, and keep in mind we can make the diagnosis of liver cancer without AFP. That is not part of the criteria. It is the fact that he had a lesion that was hypervascular in the setting of cirrhosis with delayed washout. That's the diagnosis of liver cancer. And imaging, ultrasound is the current guideline for screening. because as we know, about 1/3 of patients do not make AFP. But needless to say, we know from several prospective studies that a high AFP is not a good prognosis. But here, this is a patient who has a solitary lesion with maybe a small satellite in the right lobe. On this image, you see the tumor slightly with a blush, the main lesion. So what should be done next? Resection, RFA, TACE, systemic treatment. Well, what is this patient's stage? And they have a solitary lesion. They're well compensated, good performance status. We heard about the Barcelona system, and this is a patient who will not be a resection candidate because they have portal hypertension. It's a little large for RFA, but probably chemoembolization would be very appropriate. They do not have advanced disease, and this is a patient, therefore, who would not get systemic treatment, but some local regional treatment like a Barcelona B. So in this case, the patient undergoes Y90, a procedure that has been developed as a way to treat tumors in the liver. There were 2 large phase 3 studies evaluating Y90 in advanced disease this year versus Sorafenib, and those were negative. But in a patient with local disease, this may be a reasonable approach other than TACE. Has a good response. However, over time, they develop nodules in the chest, and at this time, the patient has developed metastatic disease. And this relates to this idea, as we heard, that this isn't a static diagram. And really, patients with early-stage liver cancer or non-curable liver cancer, if they don't die of cirrhosis, if they don't have some other comorbidity, eventually they will develop features of advanced disease. And at that time, it's systemic treatment. And as we're talking today about the evolution of systemic treatments in liver cancer, from first-line options to second-line and potentially beyond, the only way we're going to get patients to maximize this sequence is to triage patients to appropriate treatment strategies. That is to say that before that patient undergoes his or her next chemoembolization procedure, you need to ask yourself, am I compromising their liver function or their chance of getting proven systemic options that have been proven with a high level of evidence, as we'll discuss. And importantly, you don't need to have disease outside the liver to have metastatic disease or advanced disease in liver cancer. The liver is a pivotal organ, and bulky disease in the liver, vascular invasion in the liver, these are signs of an advanced tumor. So the standard for the past 10 years has been Sorafenib. You're very familiar with the 2 studies done in North America and Asia that had a very consistent survival benefit, a 30% decrease in the risk of death in both studies. While the magnitude of benefit was the same, the control arms did behave somewhat differently, but needless to say, this has been the standard of care for advanced liver cancer. Interestingly, there's been a lot of analysis of subgroups from these studies, and here looking at the SHARP study. And what we've seen is a pretty consistent benefit across various clinical groups. But what is striking, and what's something to keep in mind as we evaluate data with new agents in a hepatitis C population, there is the sense that the survival for this group of patients is better than the median, which was about 11 months in the SHARP study. But also keep in mind that in systemic treatment studies, you can still have Barcelona B or intermediate stage disease. That means no macrovascular invasion, no extrahepatic spread, if you are refractory to chemoembolization. So if you have a chemoembolization, you respond, recur, have another one, but 2 months later you have multifocal disease in the liver, that's an advanced tumor. That's beyond the role of TACE. And what you can see here, there's a significant benefit to systemic treatment. Sorafenib, we're very comfortable with managing the toxicities by now. They really come as GI and dermatologic, hand-foot skin reaction, and diarrhea being the most common, and generally can be managed with supportive care or dose reductions as needed. So what we've learned from having Sorafenib around for several years now is that we can improve survival in patients where the competing risk of liver disease is minimized. So again, if you have someone who has decompensated liver disease, they're going to die likely of their cirrhosis before they die of a tumor. And importantly, when we design clinical studies, we design them to minimize the risk of death from liver disease versus cancer. That's unique to HCC, and that's why the Barcelona staging system has become widely adopted, because it takes both those components, underlying liver disease and tumor characteristics, into stratifying patients. It's important to see patients regularly. It's an oral drug. You don't say, take it, I'll see you in 3 months. You still need to see them back. And outcomes will depend on various clinical factors. While there's a consistent benefit, the degree of that benefit might vary based on various clinical factors. And how sorafenib actually improves survival, I would argue, is still ultimately unknown. It's certainly a VEGF kinase inhibitor. There's a lot of data that angiogenesis is important in liver cancer. It also hits several other kinases. But needless to say, it improves survival without improving response rate significantly, likely by delaying progression. There's been a lot of work on hand-foot skin reaction. There's been a phase 3 study that looked at using prophylactic urea-based creams. This was published in JCO a few years back. That actually showed that prophylactically addressing this, patients do better than waiting till it happens. And here's just some of the grading for just practical management. Grade 1 is mild. You could either hold drug or just have them avoid toxicities. Grade 2, again, using urea-based creams and topical agents. And grade 3, you probably need to take a break and consider a dose reduction. So things are changing very quickly, and we'll touch on these various agents moving forward here. So we have not had another drug approved in the frontline setting of liver cancer for over a decade. That's not because of lack of trying. There's been numerous studies, about 7 failed phase 3 studies that have challenged sorafenib and not met their endpoint. This includes studies that were based on non-inferiority, not just superiority. The REFLECT study that was presented at ASCO was a large phase 3 study comparing the multikinase inhibitor Lenvatinib versus sorafenib. This was a study that had very typical inclusion criteria as other advanced studies, with the one caveat that excluded patients who had main portal vein invasion and those who had more than 50% of their liver involved. That was somewhat unique to this, and this is a group of patients who notoriously do very poorly. But needless to say, they were child PUA. These are the stratifications. Lenvatinib is dosed by weight. Different from sorafenib, primary endpoint was overall survival. This is the primary endpoint. It met its primary endpoint of non-inferiority. The study was designed that if it met non-inferiority, then they would look at superiority. It did not meet its superiority endpoint, but important to say, sorafenib performed very well here, 12 months. That's not a number that's been seen in frontline studies with sorafenib, and we can speculate why that is. There were some imbalances. Maybe the sorafenib arm had more hep C patients, and we talked that they might do better. But also we excluded those patients who had main portal vein invasion or bulky disease in the liver, which in other studies they were included. Lenvatinib, 13.6 months, had a ratio of 0.92, and unlike any other study against sorafenib geared for inferiority, the upper limit was 1.06, where the cutoff was 1.08. Now, while it did not prove superior in OS, it did meet other secondary endpoints. And here you see essentially a doubling of PFS with Lenvatinib versus sorafenib, hazard ratio of 0.66. A doubling of time to progression, again, a hazard ratio of 0.63. And very provocative, we saw a significant response rate, probably for the first time in a randomized study with a drug in liver cancer. Keep in mind, this is being measured by modified RESIST, not conventional RESIST. Conventional RESIST, looks at the sum of the longest diameter of the tumor. Modified RESIST is taking into account the sum of the longest diameter of the enhancing component of the tumor. And again, we talked about how liver cancers have a unique radiologic appearance in the liver. And modified RESIST was designed given the fact that drugs like sorafenib improve survival without response, but maybe we're just not capturing response in the right way. And modified RESIST was designed to try to capture this biologic activity. And here you see a response rate of 24% versus sorafenib 9%. Remember, in the SHARP study, sorafenib had a response rate of about 2%. That was by conventional RESIST, but by modified RESIST, this is significantly improved. And I had commented before, this was initially seen in Ghassan's phase 2 study of single-arm sorafenib. Now, the drugs do differ a little bit in toxicity. While both are VEGF kinase inhibitors, lenvatinib is very potent and also has activity against the FGFR pathway. And here you see hypertension being a little more of an issue with lenvatinib, though manageable, whereas hand-foot skin reaction is more frequent with sorafenib. Otherwise, both drugs can cause diarrhea, appetite, and other low-grade toxicities. So clearly a positive study, the first positive study in frontline. Presumably this drug will be approved at some point and will be a treatment option for patients. Now, before lenvatinib, the first new positive study in any setting in liver cancer was the RESORCE study. This was in the second-line setting, and again, we saw failures of Brivinib, ramucirumab, everolimus, and RESORCE evaluated regorafenib, again, a very potent VEGF inhibitor, as well as other kinases, including TIE2. And here you see a well-designed study with patients who had documented progression on sorafenib, right? So patients had to have RESIST documented progression. They had to have tolerated sorafenib for a minimum period of time. And then they were randomized in a blinded fashion to regorafenib 160 milligrams daily, 3 weeks on, 1 week off, versus placebo. The primary endpoint was overall survival. Remarkably, this data looks very similar to what we saw with sorafenib in the frontline setting. Here we have patients who were progressing on sorafenib and then were randomized, and here placebo 8 months. So 8 months is now the benchmark for second-line studies. We've seen repeatedly that the placebo arm in second line will perform around 8 months plus or minus. But here, for the first time, we saw an improvement to almost 11 months, 10.6 months, hazard ratio of 0.63, a very significant finding, and now is the first high-level evidence for treatment with regorafenib or any agent in second line. I also want to point out that the time on sorafenib was equal between these two arms. It was about 8 months, which you would argue is a little longer than we might see in a larger random practice. But again, patients were selected to have tolerated sorafenib for some period of time. And the toxicities with this drug are very familiar to us, not that dissimilar from sorafenib, a little more hypertension, hand-foot syndrome, loose stool, generally manageable. But again, I think the higher frequency of hypertension with this agent compared to sorafenib probably reflects its very potent anti-VEGF activity. Now, this data set we presented last year, which is very provocative, right? Because now we have a sequence of frontline sorafenib transitioning to regorafenib at radiographic progression. Historically, sorafenib had no response rate. There was nothing to offer patients later. So what was progression on sorafenib? And even if patients were progressing radiographically, you could make the case to keep them on drug because even without a response, we improved survival. In the context of the RESORCE study, we looked at the survival from the time of starting sorafenib to the time of death on study. And here we saw in the overall population that was over 26 months in the treatment arm, about 20 months in the control arm. This is in the rest of the world as compared to Asia, so a consistent delta, and here in all patients. And even we've looked at some benchmarks, and at every benchmark, even going out to 3 years, there's still more patients on the regorafenib arm. So the conclusions from this study, it's clearly an active drug. It improves survival. We also saw that this drug has a response rate of about 9% by modified RESIST, differentiating it from sorafenib. But at this time, it's the only study with phase 3 results until this meeting. And that is the data with Cabozantinib. I'll cover it briefly. The phase 3 study grew out of this randomized discontinuation study, and to be honest, was based on a relatively small number of events to launch this phase 3 study. But needless to say, Cabozantinib is different from some of the other molecules we've looked at in that it has activity not only against VEGFR, but also c-MET and AXL. c-MET, I would argue, is not a validated target in liver cancer at this time. There's been no proof of concept that MET is a driver, and that is largely based, I think, on the failure of Lenvatinib. And there was the thought that high c-MET expression was a negative prognostic marker, But if we look at the control arm in that study, it was over 9 months. It actually is better than the random control arms where we see 8 months. So the role of MET, I think, is still needs validation. But needless to say, Cabozantinib now has positive phase 3 data. In this study, it was a mixed population of both patients who had prior Sorafenib as well as no prior Sorafenib. And here, seeing at 30%, there were some real responses, either by imaging or AFP response. The toxicity profile here is similar to drugs in the class, hand-foot skin syndrome and diarrhea, and some incidents of thrombocytopenia, but probably not clinically relevant. So the Celestial study was the definitive study. This took patients after 1 prior therapy, but also took patients who had 2 prior therapies. Again, a very unique population and study design, which all the other phase 3 studies had ignored. Here you see placebo 8 months, very consistent to what we've seen in the others. And keep in mind, this is a mixed population of 1 or 2 lines of therapy, but that improved to 10.2 months. Certainly doubled PFS. Response rate is greater, but still single digit, probably being driven by disease control rates, hazard ratio of 0.76. Very exciting now to have 3 positive phase 3 studies in the course of about a year and a half. And here, just some of the toxicities that came out of the abstract. So ramucirumab is an interesting molecule. It's a monoclonal antibody to the VEGF receptor. It's approved in lung cancer and gastric cancer, and initially was evaluated in this study, which took, again, all comers who progressed or intolerant to Sorafenib, randomized to ramucirumab or placebo. This was essentially a negative study. Overall, it was a negative study, did not meet its endpoint. However, retrospectively, it was evaluated by several clinical parameters, including this biomarker of alpha-fetoprotein. And what was striking, that if you had a AFP of less than 400, there was no difference. However, in the high AFP group, you had a hazard ratio of 0.67, placebo 4 months to 7.8 months. We're waiting for the results of the REACH2 study, which now is a biomarker-selected population of elevated AFP greater than 400 and enrolling them and randomizing them to ramucirumab or placebo. This could be, if positive, the first biomarker-driven therapeutic in liver cancer. And again, importantly, this study validated the fact that high AFP is a poor prognostic sign. Placebo, high AFP 4 months versus 7.6 months. So now as we move into the design of second-line studies and think about important stratification factors, many of the next-generation studies are including AFP. And here is the REACH2 study, very similar design, but fewer patients, because now in a targeted population, presumably you won't need such a large number to see a benefit. So this slide summarizes some of the studies we've discussed, as well as others that had failed of recent. So Lenvatinib positive, non-inferiority, Cabozantinib positive, Lenvatinib failed, unfortunately. Ramucirumab is still in development. Apatinib is really being developed ex-US. So, talking about biomarkers and selection in liver cancer, there's been a lot of interest in the FGF pathway. Fibroblast growth factor receptor is a receptor tyrosine kinase. And while some of the drugs we're pursuing are dirty FGFR inhibitors in that they hit VEGF and FGF, for a long time, there's been some science behind FGF19, and this is some work I was involved with, where FGF19 amplification was identified as a potential driver of liver cancer development. It was actually an accidental finding when FGF19 was induced in mouse skeletal muscle. To understand that biology, the mice formed liver cancers. Total serendipity. And then developing a monoclonal antibody to FGF19, which binds to FGFR4, it was shown that those models that have high FGF19 amplification actually respond to this monoclonal, and that was shown in mice as well. And you can see here, this work came out of a study that looked at several different amplicons in liver cancer, transfecting them in to try to understand the drivers. And you can identify tumors that have this event with FISH. there's a probe for cyclin D1, and FGF19 is right next to cyclin D1, and you can see very clear difference between those that are amplified versus non-amplified. And so now there's a whole suite of FGFR4 specific molecules going into development. And I'd say the development is going to be challenging as we see more drugs approved that are active in second line, and maybe we're going to be talking about third line HCC more, or identifying predictive markers and moving them earlier, but in subsets of patients. This data was presented at ESMO, and in here they're looking at patients enriched by immunohistochemistry, not necessarily just by FISH, versus immunohistochemistry negative. And interestingly, here looking at immunohistochemistry, they actually saw some real responses in patients. Here you see some that are amplified. Amplification in this cohort did not necessarily be required for response. And at least by their IHC data, no responses in those that were not FGF19 positive. Small numbers, early data, but very intriguing that perhaps a biomarker approach will play a role in the future. So there's no doubt we're making progress in liver cancer. It's an incredibly exciting time, and we are improving survival. Important to improve survival is to get patients to the right treatments, right? And that means taking into account their liver function as well as their anatomy. And to keep a patient undergoing continued local regional treatments and then having them evaluated for systemic treatment when they have ascites, high bilirubin, we're not going to be able to impact them. So if we're doing research and generating positive data, and I would argue in the setting of Y90 negative data, in randomized studies, it's important that we interact with all our colleagues of this multidisciplinary team so that they're aware of the data and that the improvements in systemic treatment hopefully will change the natural history. And like I demonstrated with the Sorafenib to Rego sequence, an impressive number for that clinical trial population. But if we now have several drugs approved in second line, there's no way patients will get those second or third line if they don't get to front line. So again, I'd emphasize clinical trials are always the best option because the only reason we're here today is because of all the participation in clinical trials and all of your support.
Thank you so much. That's excellent. Thank you so much. Thanks. That was great, Richard. If anything, I will take one question from the audience because it's pertinent to what you have discussed. And understandably, that moving from one choice of therapy to literally 4 that you spoke about today, this is going to, no doubt, create a certain question about how to choose. And the question that I have for you, do you have any notion yet what the choice might be in regard to the first line being Sorafenib versus Lenvatinib, and second line being the Regorafenib versus Cabozantinib, and especially you can take it from the perspective, as an example, the etiology, Hep B versus Hep C. But you can, of course, address it from any way you like.
Yeah, so it's a good question, and certainly I think we're going to see as the Lenvatinib data is published and we look at that closer, that there might be a population of patients that might benefit greater from Lenvatinib versus Sorafenib. I think the response rate is very intriguing, and that has to be balanced against what is your continuum in second line. I mean, obviously all the second line studies have been done after prior Sorafenib, right? And so there's a leap of faith, I guess, to some degree that if you start with Lenvatinib, is the sequence to Rego going to behave the same as Sorafenib to Rego? And no one can answer that question without prospective data, and I don't know if that's going to come by anytime soon. We have a lot of comfort with Sorafenib, but again, I think for some patients, maybe this high AFP group, for example, where you'll see the hazard ratio might be a little less, that might be a good group for Lenvatinib over Sorafenib. Toxicities will come into play as well. But I think obviously both of them are very available and reasonable options. In second line, I think we need to ask ourselves, how long is this patient going to live, right? Because for patients who are rapidly progressing and only have shot at one drug, I think the hype and hope about nivolumab, which we didn't talk about, but the label is a response rate of 14%, 14.3, with a duration of response of 16 months. So that means if you respond, you're going to do well, right? But 85% of patients don't respond, right? So, you know, there's the hope, and I would think that many of us, God forbid, if we were faced with a situation, would want a chance at a drug like nivolumab or pembrolizumab. So, you know, it's a matter of saying, does this patient have enough time that they're going to get more than one drug in second line, in which case you have the option of going to Rego and then Nivo, or vice versa, versus you only have one shot at a systemic agent, and assuming they're healthy enough, right? I'm not saying, you know, if someone's decompensated, you treat them, but you know, there's patients who are only going to make it 6 weeks unless they respond, and you need some disease control.
To be fair, even though, you know, you brought this aspect in regard to checkpoint inhibitors, but in all fairness, I would like to keep that part of the question for Anthony to discuss. But no doubt that you're right in other words, we have to put the whole picture. But now that's the TKIs by themselves with 4 on board is actually confusing by itself, and it needs a lot of homework in regard to find out how to really pick and choose and what will be the appropriate criteria to do so. But with this said, we're going to keep the question of the TKIs aside for a second, and we'll move on to the third part of the program, and we'll talk about the understanding and realizing the full potential of immuno-oncology in advanced HCC.
All right, well, Doctors Abu Alpha and Finn are a tough act to follow. And contrary to common belief, I do use targeted agents and TKIs in HCC. But I will focus my talk now on immunotherapy. So we start with a case. A 71-year-old male, this is a real story, had chronic hepatitis B, and the hepatitis B had not been treated until 2 years prior to his presentation. Presented with abdominal pain and weight loss, was found to have elevated liver enzymes and an AFP of over 1,000. On a multi-phase CT scan, he had a heterogeneously, mildly enhancing infiltrative mass, measuring 6 centimeters with extension into the right and left portal veins, so immediately making him a BCLC stage C patient. Because they did not meet the typical imaging criteria of enhancement with washout, patient underwent a biopsy and had poorly differentiated HCC, had Child-Pugh cirrhosis. Patient was initially started on treatment with Sorafenib as per standard of care. Even on the first 2 scans had some growth of the existing disease, but at 5 months there was significant increase and new abdominal lymph nodes that enlarged on 2 subsequent scans, worsening of the portal vein invasion, and significant increase of the AFP to over 25,000. He was at that point recruited into the clinical trial with nivolumab. Within 2 months, had a partial response. AFP decreased to less than 100. And after 10 months on nivolumab, was noted to have a new lymph node measuring 1.4 centimeters. So by RESORCE definition, that's not even a measurable target lesion, but nonetheless, it was new. So stayed on study. 4 months later, he actually had more adenopathy, and at that point, pain was coming back. So he had also clinical progression, was taken off study. So, you know, when we talk about cancer treatment nowadays, we cannot escape talking about immunotherapy in multiple tumor types. And the focus has been on the checkpoint inhibitors, which are highlighted on mostly on the right side here of this circle. So these are the brakes. These are the proteins that are expressed on the T cells and have ligands on the tumor cell, and which really inhibit the T cell activity against the tumor. So targeting PD-1 and targeting CTLA-4 are the 2 that have the longest track record in cancer, but certainly there are other checkpoint inhibitors that are being targeted now in clinical trials, and some in combination, such as LAG-3 and TIM-3, and on and on. And here is probably a partial listing, I'm sure we missed some, of the compounds that target these various checkpoints. On this side are actually what I call the gas pedals. So these are more agonists that actually invigorate the T-cell activity. And again, many of them are in clinical trials, including OX40 and GITR. and anti-CD137 being evaluated in clinical trials. There are also agents that target more of the natural killer cell population. So I guess in a nutshell, there are many ways to invigorate the immune system to fight the cancer. And the basic principle with the checkpoint blockade is familiar to all of us, so I won't spend too much time. But basically, the interaction between PD-1 on the T cell surface and PD-L1 and PD-L2 on the tumor cell leads to the inhibition of the T cell. So basically, the T cell receptor does not recognize the tumor as foreign and is rendered inactive. And the antibodies that bind to either PD-1 or to the PD-L1 interrupt this interaction and reawaken the T cell activity against the tumor. Now, for a long time, hepatocellular carcinoma was not thought to be an immunogenic disease, right? The liver is a tolerant organ. Many things go through our livers, including from the gut, so it has to build tolerance. But we learned over time that actually hepatocellular cancer, like other cancers, has built-in mechanisms to suppress tumor immunity, anti-tumor immunity. And there are many examples of that in the literature. So the first thing that I'm not showing here is that up to 70% of patients that's in the literature with hepatocellular cancer have tumor-associated antigens that can be recognized by specific T cells. So normally you would expect if there are antigens and there are T cells, we should have some natural immunity against this cancer. But as mentioned, the cancer knows how to build in immunosuppressive mechanisms, and here are some of them. So one of them is this tumor-infiltrating T regulatory lymphocytes, which can actually suppress the anti-tumor immunity. And there is data. These are resected specimens from patients who underwent resection, where having low tumor-infiltrating T regulatory lymphocytes and high cytotoxic CD8 T cells was correlated with improved survival. Similarly, looking at PD-L1 and PD-L2 expression in resected samples, PD-L1 high expressors had worse prognosis than the PD-L1 low expressors in these resected samples. So the story with checkpoint inhibitors started with tremelimumab, an anti-CTLA-4 antibody, in a study done by Bruno Sangro. This was a single institution study where he used tremelimumab in patients with chronic hep C infection who had advanced disease and were not amenable to locoregional therapies, had Child-Pugh A or B cirrhosis, good performance status, and they were given tremelimumab as a single agent. The primary endpoint was tumor response. In this study, so these are the adverse events, and you see if you look at the grade 3 adverse events, the majority of them were elevations in the liver enzymes of AST and ALT. None of them were associated with liver failure. These were transient elevations that occurred early. So the basic principle here, this was a proof of concept that checkpoint inhibition is potentially feasible in hepatocellular carcinoma. And then looking at efficacy, as a single agent, there was an overall response rate of almost 18%, a disease control rate of 76%, median OS of 8 months, but I remind you here that many of these patients had Child-Pugh B, up to a third had Child-Pugh B cirrhosis. Also, interestingly enough, that there was some evidence of antiviral activity, as seen here by the progressive decrease in hepatitis C viral load across serial time points. Then came the evaluation of the anti-PD-1 agents, starting with nivolumab in the Checkmate 040 trial. Again, this was a phase 1/2 study. Initially, this was a phase 1 dose escalation trial. Then there was a dose expansion portion, which I'll show you a bit later, with 4 different cohorts. And this is the part that's been completed that we will discuss tonight. Then many other cohorts have been added that you have not seen the data for yet. A randomized phase 2 study of sorafenib versus nivolumab in previously untreated patients, a nivolumab in Child-Pugh B cohort, a combination of nivolumab and ipilimumab, and most recently, a triple combination with the addition of Cabozantinib. This is ongoing. So going back to the eligibility for the first dose escalation and expansion, these were patients, again, not amenable to curative options. In the dose escalation, up to Child-Pugh B7 was allowed. In the expansion, only Child-Pugh A. Patients were required to have progressed on at least one prior line of systemic therapy, or could have been intolerant to or refused sorafenib. The primary endpoint for the dose escalation was safety and tolerability. For the dose expansion, it was overall response rate. And you see a whole slew of secondary and other endpoints, including biomarkers. So this is the dose escalation part. Given the fact that this was the first time that an anti-PD-1 agent was being tested in the setting of viral hepatitis, there was extra caution given, and there was parallel dose escalation in 3 cohorts: the uninfected cohort, hepatitis C infected, and hepatitis B infected cohort. You see the dose escalation schema here, 48 total patients, and then went on to the expansion. 4 parallel cohorts: sorafenib naive or intolerant, sorafenib progressors, hepatitis C infected, and hepatitis B infected patients. The nivolumab was given every 2 weeks, with imaging every 6 weeks. The punchline from the dose escalation is that there was only one dose-limiting toxicity at 10 milligram per kilogram in the uninfected cohort, which was a grade 2 hepatic impairment. But this patient, shortly after having decompensation of the liver cirrhosis, was found to have progressive disease. And the dose of 3 milligrams per kilogram, which is the standard dose in other tumor types, was determined to be the recommended phase 2 dose. So there was no MTD. These are the baseline characteristics of the patients in the expansion phase, which are similar to the escalation. If I draw your attention to the last column here, median age of 64, so typical population, majority males. You see the ethnic distribution here. Extrahepatic disease was over 70%. Vascular invasion was slightly lower in this group than we're accustomed to, but if you add the two, over 80% of the patients had either or extrahepatic or vascular invasion. The large majority were Child-Pugh A. 40% had an AFP over 200. And these were heavily pretreated patients as far as other modalities, including, again, a large proportion, over 65%, who had prior sorafenib. And the baseline characteristics were not very different across the different expansion cohorts. How about the outcome? This was the initial outcome that we published last year. Again, if I draw your attention to the right column, the overall response rate by RECIST 1.1 was 20%, with some complete responders, but the majority were partial responses, and a 45% stable disease rate. Again, these data, as far as duration of response, were kind of early, and certainly the overall survival at the time of the publication was not mature yet, so I'll show you some subsequent data. Important to note that the responders happened across all etiologies, as you see here. Of course, these cohorts were not powered to be compared against each other, so it'd be hard to say, oh, hepatitis B had a lower response rate than uninfected. Again, it was not powered for that purpose. So this is visually showing you the responses occurred across all cohorts, and that the spider plots looked actually quite similar, and emphasizing here the durability of the responses, which I'll show you numerically in the next slide. So this is updated data that we presented at ASCO 2017, where we regrouped the patients in a different fashion. So we looked at the sorafenib naive patients in both the escalation and expansion cohorts. And these are sorafenib experienced in the escalation, and these are the sorafenib experienced patients in the expansion cohort. And two important messages here. The median duration of response was somewhere between 17 and 19 months for all of these patients. The patients who responded for a long time. The other important message here is that if you look at the circles, the majority of the responses occurred within the first 3 months, with the median time to response, as you can see here, ranging between 1.4 and 2.8 months at the latest. So if they responded early, and then they responded for a long time. Looking at survival data, again, with the same grouping of sorafenib naive, this was 80 patients, and the sorafenib experienced, which was about almost 150 patients. You see here that the median overall survival in these 80 patients was 28.6 months, almost 29 months. Again, this is single-arm study, but nonetheless, intriguing number. And then the sorafenib experienced patients' median overall survival of 15 months. And then you see the survival rates at 12 and 18 months. Again, quite impressive for this population. What about safety? So if we look at the expansion cohort of 214 patients, 18% had grade 3 or 4 toxicity. The majority of the toxicities were laboratory abnormalities, such as AST and ALT elevations, and there were some amylase and lipase elevations that are not on here. And the rest of the toxicity profile was certainly consistent with what was seen in other tumor types with checkpoint inhibitors. None of these patients with AST and ALT elevations had, except for the patient that we called the DLT, had really liver failure. So with that in mind, overall, this certainly looks like a therapy that's well tolerated, but we cannot overlook the potential for immune-related adverse events, and there was, again, a small fraction of them in Checkmate 040. These are low-rate events, but can be life-threatening potentially. And the way I tell patients about this is that your immune system can simply overshoot and cause inflammation almost in any organ, as highlighted here. And the challenge for us as clinicians is to watch for these potential events and intervene early and appropriately with steroid therapy to avoid life-threatening complications. Certainly, I think the more common ones that we see in general with checkpoint inhibitors tend to be the gastrointestinal one with colitis and the pneumonitis. Certainly, some of the endocrinopathies also are important to test for as well. And then there's a smattering of others. Rashes are very common. The majority, though, are low grade and are treated with topical therapies, rarely that require systemic treatment. There is a general algorithm in all clinical trials with checkpoint inhibitors, and actually that's now translated into clinical practice. And important is that even with grade 2 events, it's important that other etiologies are ruled out, and the adverse event is thought to be immune-mediated to interrupt the therapy and consider initiating steroids at that point. Okay, so I shared with you the phase 1/2 data with Checkmate 040 that led to the accelerated approval of nivolumab in the subgroup of patients who had previous sorafenib therapy. There is an ongoing phase 3 study, Checkmate 459, which is a frontline trial of previously untreated patients with nivolumab versus sorafenib, over 700 patients. Again, a randomized trial with a primary endpoint of overall survival. And in second line, Keynote 240 is actually ongoing, and this is a randomized study post-sorafenib to pembrolizumab versus placebo plus best supportive care. Of note, at this meeting, Dr. Zhu is presenting Keynote 224, which is a phase 2 trial. There's data on over 100 patients treated with pembrolizumab as a single agent. And in the abstract, you will see that there is a response rate there of 16%. So certainly in the same range of what we're seeing with these checkpoint inhibitors in HCC. And again, more details will be in that poster. Important to mention here at this point that in Checkmate 040, we looked at PD-L1 expression, and I didn't show you that slide. And we looked at PD-L1 expression on tumor cells with a cutoff of 1%, and there were responders in both PD-L1 positive and PD-L1 negative patients, so it was not a great predictive marker or a separator for response. Now, as I alluded to earlier, there are many mechanisms by which these tumors inhibit the immune system. And for that reason, there are multiple combinations emerging. Here is an example of a combination of 2 different checkpoint inhibitors, so targeting concurrently PD-L1 and CTLA-4 with durvalumab and tremelimumab. Again, there were some safety data and early data presented from this phase 1/2 study for the combination of durvalumab and tremelimumab, which I'll show you here. In the initial 40 patients, there is a response rate of 18%. And you see here the breakdown by etiology. Again, the numbers are small here, so I would caution you against making major conclusions that the uninfected patients do a lot better than Hep B necessarily. Again, the numbers are too small at this point. But what's important in this phase 1 study was the feasibility of doing the combination of anti-PD-L1 and anti-CTLA-4. And the rate of grade 3 and 4 events was about 20%, so not much higher than what we saw with single-agent PD-1 agents. Now, this has evolved to a first-line randomized phase 3 study with a very large trial, Child-Pugh-A patients, again, previously untreated with systemic therapy. And here the control arm is Sorafenib versus these 3 experimental arms of durvalumab, and then 2 different schedules of durvalumab and tremelimumab with a primary endpoint of overall survival. Now, immunotherapy does not stop at checkpoint inhibitors. And there are many other ways of engaging the immune system through cellular therapies, both autologous and allogeneic, through the usage of dendritic cells, peptide-based vaccines. And briefly, I'll give an example here of a very elegant trial that's actually a phase 3 study that was done in Korea for patients who underwent a resection or ablation or ethanol injection. Most of these patients had hepatitis B infection and had relatively small tumors. But nonetheless, in this study, they were randomized to supportive care versus autologous cytokine-induced killer cells. So the patient's killer cells was actually cultured ex vivo. They were cytokine-induced and then reinfused into patients. And you see here that the primary endpoint of recurrence-free survival was met, with the patients who received this therapy doing better than the controls. And again, this should be validated in a larger patient population and a more patient population that we see typically in the Western world as well. But nonetheless, intriguing set of data that goes beyond checkpoint inhibitors. Now, as I alluded to earlier, there are many emerging combinations that are scientifically sound. I will mention a few here. The idea of combining targeted therapy, especially anti-angiogenic agents, to group them broadly here with checkpoint inhibitors is sound. There is data that some of these agents do increase PD-L1 expression. They may also enhance or induce the T regulatory cell population. They also may enhance antigen presentation through the induction of hypoxia and other mechanisms. So there are several examples now of trials that are launching, combining checkpoint inhibitors with TKIs, including Sorafenib, Regorafenib, Cabozantinib, Lenvatinib, etc. The concept of combining ablative therapies with checkpoint inhibitors is also gaining momentum. The idea here is that the ablative therapy could enhance the antigenic presentation by causing apoptosis and necrosis of cells, and maybe enhancing the tumor-specific T-cell response. The effort that's been published so far, mostly focusing on safety, is by Tim Gretton at the NCI, who combined ablative therapy with tremelimumab and showed that that was feasible. The efficacy data is early to comment on. There are other trials now combining checkpoint inhibitors with local regional therapies, including Y90 and TACE. So, in summary, anti-PD-1 and PD-L1 therapy has shown favorable safety and early efficacy in HCC. I think the challenge is about expanding the benefit of immunotherapy to more patients. There was a comment earlier about the fact that, well, yeah, maybe 20% or less do respond. So how do the patients with stable disease, or how do the patients who have some reduction but not a partial response, how do they do? So I invite you to see our poster tomorrow of an update on Checkmate 040, where we have looked at the survival based on the reduction in tumor size, including the patients who had progression. And we also have commented on the unconventional benefits in the patients who had progressive disease and looked at their survival as well. But certainly, we still have a challenge for better biomarker development to enhance patient selection, especially that we now have multiple therapies, and to minimize unnecessary exposure and toxicity, Combinatorial therapies are the way of the future, certainly, and there are many other emerging immunotherapies that we did not talk about here, including combinations with epigenetic drugs as well. I think the onus is on us to expand the safety experience to patients with moderate liver dysfunction, like the Child-Pugh patients, to see if we can benefit them as well. And again, explore combinations with earlier lines of therapy, including current standard of care, such as TACE for the earlier stage patients.
I would like to ask one more question that actually is from the audience. So for the patient to progress on the anti-PD-1 treatment, either from the beginning or who progress after response, do we have any sense what other immune pathways would be abrogated at that time?
That's a great question. I mean, and this is where a lot of the scientific focus is nowadays. In HCC, I think we're starting to scratch the surface to understand pathways of resistance to immune agents. But if you look at other, other immune treated tumors, certainly pathways like LAG3, TIM3 are emerging as important pathways to target after progression on anti-PD-1 therapy. But there are other things that seem to also emerge beyond, again, the checkpoints, like the myeloid-derived suppressor cell population seems to actually play an important role as well. So I think we're scratching the surface, but this will be an important area of focus in the next few years.
We'll carry on to the fourth part, which is to look and examine the ongoing clinical trials combining the therapies being the local plus the treatment modalities in HCC. So with this said, I really bring in a very straightforward agenda, which is based on what we perceived before in regard to the divorce part and the marriage part. Because if you recall, when I showed the BCLC, I showed the BCLC-B where the local therapy might apply, and then I showed the BCLC-C where the systemic therapy might apply. And the question is, are we really splitting them and trying to kind of, collude with each other, or is there a chance for a potential marriage over here? And the story comes from the divorce ticket from probably the most recent data, the SARA study, which was presented in the last April at the EASL, which looked at the CERT versus Sorafenib in patients with unresectable HCC with BCLC-C or BCLC or A or B. In other words, technically anything up to C, patients were randomized to the CERT versus Sorafenib, with the primary outcome being, of course, overall survival. That study has actually, unfortunately, showed negative outcome. As you can see over here, the CERT median survival was 8 months, and that of the Sorafenib is 9.9 months. It really showed that we can treat BCLC-C patients with a local therapy approach like the Yttrium-90. Also, we can imply that the Sorafenib will be applicable for the local disease per se. With this said, also it showed that progression-free survival was also not in favor. As you can see here for the CERT, it was 4.1 months, for the Sorafenib 3.7, again without any statistical significance. With a study of that nature, it appears to be that the overall survival was non-significantly different. In addition to that, the response rate, if anything, was probably more favorable in regard to the CERT, considering the local nature of the disease, of the treatment. And the PFS also did not show any difference per se. And understandably, the treatment-related adverse events were less with the CERT, considering the local nature of the treatment. By the way, there was another effort that Dr. Peace Chow, our good colleague from Singapore, has presented at ASCO last year, which is the Sorafenib, which is CERT versus Sorafenib in the Asian population, which again looked at the same or very close criteria to the one that I showed on the SARA. Again here, looking at overall survival as a primary endpoint for the disease. And if anything, that trial also was negative. As you can see over here, the median overall survival for the CERT was 8.84 months. And in addition to that, for the Sorafenib was 10.22, which is similar to the same outcome that we have seen with Dr. Finn in regard to the use of Sorafenib. And again, this was one more time confirming the non-superiority for the CERT. CERT treatment was associated with the higher RESIST 1.1 response rates. Again, same thing as we saw in the SARA. And there was, again, significantly lower adverse events with the CERT compared to the Sorafenib per se. the oncoming results of the ceramic study, which is still ongoing, looking at the spheres plus sorafenib versus sorafenib with the overall survival as being the primary outcome. And this is a important kind of, marriage approach where a local therapy plus a systemic therapy might probably benefit the patients with local disease rather than try to make one versus fight against the other. For that reason, actually, there's quite a bit of those trials, including the STOP-HCC study, which is looking at therapies, followed by sorafenib versus sorafenib. Again, we're awaiting for the results of that, with the primary outcome being overall survival. And by the way, this is not necessarily a new concept to us, because we've been rather very busy, all of us, in regard to understanding and interpreting the data that came and started actually with Dr. Kudo in Asia, looking at TACE, stress arterial chemoembolization, followed by the sorafenib versus the transarterial embolization without any further treatment. And as you can see over here, everybody got PACE, and then patients were randomized after a certain period of time to either sorafenib versus placebo, and trying to look at the primary outcome being time to progression, and secondary outcome, they looked at overall survival. If anything, that trial did not show a benefit. As you can see over here, based on the independent time to progression, there was no difference between the 5.4 months for the TACE sorafenib versus the 3.7 for the TACE placebo. This, however, actually brought a very interesting concept that came out of the group in Bern in Switzerland that looked at was it really done in the right way? Because remember, when the Asia study was done, there was a concern that there was a relatively long period of delay between the TACE time and when sorafenib or placebo started, because of the concern about safety at that point. And as such, they came with three theories about what we call a sequential approach, where technically you do the TACE followed later on with the sorafenib, but there is also a concept of what we call interrupted, where you do the TACE, but you stop immediately at the TACE time the sorafenib while you go it through and through. And of course, the third one will be at the continuous approach, where you just go it through and through. And of course, at that time, there was a solid argument that safety will not be necessarily an issue, and as such, probably it will make more sense to kind of, catch on that probably angiogenic flare that occur after the TACE, is maybe catching it up with an anti-angiogenic like sorafenib will probably make sense to just go through and through, i.e. with continuous approach. For that reason, a certain trial did occur, and this is a space study that was done by Dr. Riccardo Lencioni, and that looked at a through and through approach where patients were embolized at the same time they were given the sorafenib at the whole time, and as you can see over here, with the primary endpoint being the time to progression. Interestingly, that trial came also negative, as you can see over here, with no difference in regard to the overall survival, which was a critical component of the trial as well. This was repeated on more than one occasion, pretty much with almost the similar eligibility criteria and similar design to the study. And this is a TACE2 study from the group in the UK, Dr. Tim Meyer and colleagues, which showed again that the combination of the TACE sorafenib did not really differ in regard to the overall survival compared to the TACE placebo, as we can see from that curve as well. And of note, there is a third effort that was done here in the US, which is called the ECOG 1208, which is a study that we're still awaiting for the reports of in regard to the outcome, but understandably, it will not be much of a difference in regard to the TACE2, as we can see over here. And this is the ECOG trial of the TACE sorafenib versus TACE plus placebo. Interestingly, all what you thought about this angiogenic flare, which, by the way, is totally validated in regard to the VEGF that actually goes up in an incredible amount after a TACE, and that's why the concept of giving the anti-angiogenic being sorafenib. But on the other hand, there was a concept about maybe the flare might be also of immune activity, exactly as Dr. Koueri explained to us about how the immune modulation will be an important target in regard to HCC, as nicely explained in the beginning. And of course, Dr. Koueri already mentioned the combination of the tremelimumab plus some form of local therapy that was done and reported here by Dr. Duffy from the NCI group. They no doubt have shown that there could be a value to the combination per se, and as you can see here from the swimmer's plot, this kind of left right lower corner of the outcome is the one that we are all aspiring for. There could be value for that concept. This was really more of a pilot, to kind of like look at different forms of local therapy, but not necessarily pinning on regard to one specifically of them. But however, there is already a serious effort that's currently ongoing, looking at transarterial chemoembolization plus nivolumab. And as you can see over here, this is copying the concept that came out of Switzerland in regard to when do you give the two therapies. And as you can see, the 3 cohorts in that trial are not really dependent like a phase 1 on the different doses of the drug, but rather on when do you give the drug. And if you can see here, in first cohort, we'll do a sequential where we pretty much do the embolization followed by nivo. The second cohort, we will actually give some nivo, interrupt, get the taste, and then continue with nivo. And the third will be actually continuous, where it's just going throughout. And we are waiting for the data of that important effort that we are leading from Memorial. By the way, this is not really the only effort that's looking into the potential for the checkpoint inhibitors to really play a role in regard to the combination with the local therapy. As you can see here, this slide is showing an ample amount of data that could be coming out. And I think, if anything, this really tells us that there is a clear understanding that this is a concept to be really analyzed and understood further. And of course, we look forward to see how it might evolve into that marriage concept that we're talking about regard to the combination of local plus systemic therapy. As already was also alluded to by Dr. Kuweri, the concept of immunomodulation is not necessarily only to be driven by the checkpoint inhibitors. If anything, there's a very important trial that's ongoing, which is looking at the vaccinia virus with a embedded tyrosine kinase, which actually look at injection directly into the tumor. That's followed by Sorafenib versus Sorafenib. And this is, again, looking at the combination of therapy that's compared to the systemic sole Sorafenib use. And this is a trial that's currently ongoing, and we'll await for the results, and we'll see if it might explain the potential combination of 2 approaches being a local plus systemic. So if anything, I would say that the local and systemic approaches to therapy clearly are not able to replace each other in regard to what we saw from the divorce component. But on the other hand, the combinational work is still underway, and no doubt that the scientific arguments for it are rather very valid, and it will be very much worth it to see where they might take us. So this brings us to almost the conclusion of the program, and of course we would like to entertain a few questions. But what did we learn today? If anything, that we have potential treatment options are as follows. We have, in regard to the first-line therapy, the Sorafenib, which was already FDA approved, and the Lenvatinib, which is to be approved still by the FDA for the HCC. In regard to second line, we have already approved the Regorafenib as well as nivolumab with the conditional approval that's awaiting the results of the 459 study that Dr. Kuweri spoke about. We have the Cabozantinib, and of course in the third line, because of the eligibility criteria of the Cabozantinib, could be also a third line treatment over here. But again, this map is yet to be evolving further, but it's fascinating and it's really something to be very proud of that we moved from 1 drug now to at least talking at 5 drugs. So this brings us to really understand that there are still many unanswered questions in regard to the treatment of HCC, among which that transition of therapy from the local to systemic that we try to at least address with the concept of some of the trials that we brought up, but not necessarily that I have the final answer with, in regard to the sequencing of the systemic therapy. And I think this is a very important question, as I addressed or asked Dr. Finn in the beginning. The lack of the biomarkers for response, we still don't know what do they mean. And of course, the selection of the patients, which therapy you will give, as we also asked Dr. Finn in the beginning per se. The question is about treatment beyond progression of checkpoint inhibitors, where, in other words, the question maybe can be readdressed as where do the checkpoint inhibitors will end up being? Are they a first-line approach, second-line approach? Will everybody be eligible for checkpoint inhibitors or not? The advent of the local systemic therapy in the frontier yet to be tackled in regard to the combination, as we mentioned as well. I would like to put some questions here that some of the audience have brought up, and I will ask the help of my colleagues in regard to those. And the question is in regard to the PD-1 expression in regard to HCC. Will it mean anything? Do we know what the expression is like? And will you apply the drug only in those settings, per se?
So the challenge with assessing PD-1 and PD-L1, again, is the heterogeneity of the assays, the variability of the assays used, and where you look for the expression. So in Checkmate 040, so far the data that we've reported is looking at PD-L1 on tumor cells only. Where it may be more helpful based on other tumor types and other studies is maybe looking actually at PD-1 and PD-L1 on the immune cells rather than on the tumor cells in the microenvironment. So that actually is being tested. In the Checkmate 040, the PD-L1 positive patients were about 20%. But again, it didn't matter as far as predicting response. So I do not believe that this will be the greatest separator, the greatest biomarker for anti-PD-1 therapy in HCC. And there is a large panel of biomarkers being tested in Checkmate 040 as well as the phase 3 trials. So we will learn more from that.
Great, thank you. And Richard, actually, quite interesting question is, and I think this is based on the fact that, as we know, FOLFOX, which was reported in JCO, has actually a positive outcome in regard to HCC, and it's already approved in China. And the question is, do you think with this kind of map that we just showed at the end that we all three spoke about tonight, where do you think, if at all, chemotherapy must still have a role or not at all in regard to HCC?
Well, I don't know that it has a positive outcome, right? I mean, the Chinese data, my understanding, the mature data did not hold up. And even in that population, even with the FOLFOX arm, it was still like 7 months, median survival. So I don't view that systemic cytotoxics play any role in this disease right now. Just to be provocative, right? I mean, there is the sense that chemotherapy and PD-1, like in lung cancer, right? There's new data that suggests that, the drugs have more activity in combination with chemo. Now, it's an interesting idea that maybe that's one thing to enhance PD-1 activity, but I don't know, with all the exciting science, that's going to be the highest priority. I don't know how much bang we will get out of that.
Right. No, I understand your point. The only thing interesting which we have shown from our group, however, interestingly, the ADIPEC-20, which we looked quite a bit on, which not necessarily that worked as a single agent, but when we combined it with the FOLFOX, there was actually some tripling in regard to the outcome. It's fascinating. We don't know yet what it means, and there is definitely a clinical trial that will ultimately be needed for that purpose, but time will tell. So with this said, Anthony, back to you in regard to the Checkpoint 040, which you nicely have reported. Do you anticipate, or the question is, do you anticipate that people might carry on that application and already use the nivolumab in the first-line setting, despite that the 459 is not really out yet?
Yeah, I do not want to guess or on that issue. I think the current label for the accelerated approval is for patients who have been previously treated with Sorafenib, and that's the largest population in the Checkmate 040. So that's where the data are. And I would urge everyone to stick to the data that's available right now from the phase 1/2 study and await the phase 3 data before applying these therapies across broader lines or even first line.
No, it's totally understandable. I think we have to wait for the results of the trial, no question. This is totally appropriate. A question for you, Richard. So you discussed at length the Lenvatinib data, and the question is kind of similar to the one we asked before, but nonetheless to be more specific. So which patient in your mindset should get Lenvatinib as first-line treatment?
Everybody's pushing that, huh? Well, I think, again, there's some patient characteristics where Lenvatinib, it has a higher response rate. And for patients where you need a response, then I think that would be a very reasonable option. There's no doubt Sorafenib improves survival. It's been shown every time, but it does that without inducing a response. So certainly for patients where response might be a priority for you, that might filter to front line. We commented about some, interestingly, there were imbalances between the arms in the study, and the publication will be out soon. But the negative prognostic factors still kind of favored Lenvatinib. So I think that's very intriguing. It's a different MOA. We showed some biomarker data at ESMO that shows that clearly it engages targets that Sorafenib does not, specifically the FGFR pathway, which I think there's evolving data that's important in some patients with HCC. So, I think you'll know it when you see it.
Fair enough, fair enough. Great. And I will actually answer the last question before we wrap it up. And it's quite fascinating. I'll take this question because it's really looking to the future. And it talks about the fact that 2 CAR-T studies came positive in regard to hematologic malignancies. Is there any CAR-T application HCC? Well, interesting enough, actually, there are trials currently ongoing in regard to CAR-T. And if anything, the targets have been varied and viewed differently. We actually, several of us are heavily involved in regard to that part of the field, and no doubt that CAR-Ts that are based on alpha-fetoprotein or AFP are being looked at, but also CAR-T that's based on some of the work that we have done on glypican-3 is also being looked at. So I like the question, and definitely this is kind of really at least is a good invitation to where the future is taking us in regard to the treatment of HCC. With this said, I would like to thank all of you for being here tonight and for contributing all the questions that you asked. And at the same time, I would like to very much thank my 2 dear colleagues, Dr. Richard Finn and Dr. Anthony Kuweri, for their contribution as well. Thank you very much, everybody. Good night.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at www.peerview.com/PVM. This educational activity is supported through medical education grants from Bristol Myers Squibb, ASI Incorporated, and Exelixis Incorporated.